Thank you very much, my good friend. Please note the time has already started 30 seconds ago, before I started. Because in the next 30 minutes, I am planning to show you my position, and we will try to understand Laurent Brochard's position, his favorite position in this debate. We know that in many cases, being in prone position can increase the PaO2, and this is likely to result from improved VQ relationships. It's important in 1 minute to understand what prone positioning can do to the patient. Actually, there are little changes in perfusion when we are in prone position, but there are changes in ventilation. And I would propose to you there are three major elements. The first one is that there is an increased stiffness of the chest wall because our dorsal region is stiffer than the ventral region. The second element is that with prone position, we can decompress the dorsal region. To emphasize this, I will use one very important scheme coming from Luciano Gattinoni, showing that in healthy individuals, open symbols, like in ARDS patients in closed symbols, when you go from left to right, you are looking at the lung height, and the y-axis represents the gas to tissue ratio, the degree of aeration of the lungs. And you can see that in supine position, there is a quite significant gradient from the upper part to the most dependent part of the lung. And this gradient becomes much less significant when we are in prone position. So if you wish, there is a more homogeneous distribution of gas. The third element is that there is less compression of parts of the lung by the heart. When we are in a supine position, the heart rests a little bit on the lungs, whereas in prone position, the heart lies more directly on the sternum. So these are, in 1 minute, the 2 minutes, the pathophysiologic basis for our discussion here. Now, always prone? No, I don't think so. Well, Professor Brochard will certainly tell us that we were monkeys in the past and that the animals are quadrupeds and they are naturally in prone position. So that we stood up, but we may be better in prone position than on our back. You know what? According to this paper just published by Robach and collaborators, maybe we could even combine prone position with upright position in patients with ARDS, and this may further improve oxygenation. Well, there may also be a decreased dead space when we are put in prone position. Again, a paper just published in Critical Care. I have no time to discuss it at length, but Dr. Charon and collaborators showed that looking at the dead space would be actually a better way to classify patients who may or may not respond to prone positioning. There could also be a little bit of alveolar recruitment. And again, a recent paper from Critical Care, I may have a bias here, showing that you could combine prone positioning and recruitment maneuver as the combined effect improves oxygenation. So yes, no doubt about this. PaO2 will go up in about 70% of the cases. But does this improve outcomes? Look at this graph showing the effects of an intervention resulting in a significant increase in PaO2 in the yellow group and not so much in the blue group. In which group would you like to be if you have ARDS? Well, I would prefer to be in the blue group. Clearly, the mortality rate is much lower than in the yellow group, and you all know what I'm referring to, obviously. I'm referring to the large tidal volume versus the small tidal volumes in ARDS. When you use a large tidal volume, you are more likely to improve oxygenation but you are also more likely to increase mortality rates. Now, Professor Brochard certainly will speak about the possible reduction in ventilator-induced lung injury. It would take too much time for me to discuss it. He may discuss rats, rabbits, dogs, but I would prefer to go to clinical trials for the last minutes of my presentation. And actually, my task is quite easy because I can just quote Dr. Brochard, again in critical care, who did another meta-analysis of the studies available on prone positioning. There are 7 trials presently available, and Dr. Abrook, who is the first author, with Laurent Brochard, had a nice way of analyzing the data, adding the data of the next trial to the data of the previous trial. And maybe Laurent will tell us that with time there is a little bit of an improvement in outcome, so that maybe in 20 years from now, if we continue like this, we will find that prone positioning improves survival rates. But the bottom line is that this may be true in the subset of patients having the most severe forms of ARDS. If you look at the most recent study of Gattinoni's group with Dr. Taccone as the first author, you can see here a quite substantial reduction in mortality rates with prone positioning in patients with severe hypoxemia. What is this? Yeah, it's the same thing. Dr. Brochard separated ALI ARDS and ARDS, and he showed that maybe in ARDS there is a greater difference, although certainly not statistically significant, than in less severe forms of acute respiratory failure. Well, Luciano Gattinoni went over individual data of these 4 studies, the 3 involving his group well, 2 involving his group and 2 others, and by doing a subgroup analysis, he reached the conclusion that in patients with severe hypoxemia at the bottom, there may be a survival advantage. And they went on, in a recent issue of Minerva Medica, doing further analysis on individual patients and showing that in patients with the most severe forms of ARDS with profound hypoxemia, there was perhaps a 10% survival advantage with the prone position. So, is the debate over? Are we convinced now? Let's keep it for very severely ill patients. Well, clearly there is another trial, which I believe has just been completed in France. We won't see the results here. You will have to come to Brussels next March to see the results. But this is a study focusing on patients with severe ARDS having a PF ratio below 150 millimeters of mercury. Finally, complications. Is it so easy to put a patient in prone position? Well, of course, we all think at the major airway complications, extubation or bronchial intubation. And indeed, there is let's say, a trend towards more complications when prone positioning is applied in these 7 studies that we are referring to. But you know what? I also went to the anesthesia literature because they often put patients in prone position for some types of surgery. And you can see a reduction in cardiac index, sometimes an inferior vena caval obstruction, sometimes an increased sympathetic tone related to this positioning even over a relatively short period of time. So in addition of unplanned extubation and the removed drains, there could be visceral ischemia, peripheral vessel occlusion, pancreatitis, contact dermatitis, shoulder dislocation, peripheral neuropathy, cerebrovascular lesion, venous occlusion, arterial ischemia, avascular necrosis of the rhabdomyolysis, abdominal, etc., etc. So this is not benign. If you are dealing with children, no problem. Take the child and turn it around. But if you deal with this type of patients, it becomes more of a challenge. Some people in Belgium like French fries, actually, French fries. And it may be a real challenge in some of them. So what kind of system do you use? That's our old Stryker bed, which was very uncomfortable for the patient. we do not use this kind of bed for prone positioning anymore, but we don't have the money to buy that kind of thing, at least unless we have a new government, but it's not there yet. So I don't know if you can afford that kind of thing. If you can turn the patients around with that kind of bed, that may be, of course, much easier, but I'm not sure that so many of us can afford these systems. So in conclusion, Mr. Chairman, I think that we could leave some place for prone positioning, but only in very severe cases. I would not do it routinely. I would consider it only in severe cases with a PF ratio of less than maybe 100. I would evaluate the benefit-risk ratio in every single case because one patient is not another. And I would carefully watch for complications. This is my proposal. Thank you very much.